So as I said to Gwen earlier on, welcome to Glasgow. And for those people who aren't familiar with Gwen Adshead, she's written extensively about forensic psychiatry and forensic psychotherapy. Delighted that you've come today. You've worked as a group psychotherapist and psychotherapist within Broadmoor, and has contributed articles on personality disorder, mentalization, the psychotherapeutic leadership, lots of topics. And most recently, I guess, come into the public frame a bit more with the book, The Devil You Know, which was serialized last year on Radio 4, co-authored with Eileen Horn, who I think is a storyteller and a friend. Is that right?
Yeah, she's a good friend of mine, but she's actually works, she's a professional sort of dramatist. She was a TV producer for many years, but she also abridges books for Radio 4. If you've ever listened to Book at Bedtime, quite often, if you listen to the end, you'll hear Abridged by Eileen Horn. So she's and she has an MA in creative writing from Goldsmiths, and she's a published author herself. So
wonderful.
Yeah.
So Gwen, over to you.
Thank you very much. So I'm just going to talk a little bit about working with violence. And I'm conscious that many of you may well already be working with violence. It's not just the province of forensic psychiatry, but I'm going to focus a little bit just on really what I've been doing as a forensic psychiatrist and how I've been thinking about it. And I'm hoping that then that will just get us into talking about that. Oh, right, okay. So share. So and hopefully that's going to work. Can you see? Can everybody see the screen?
Yes, I think people should be able to see that.
That's good. Okay, so I just want to start, as we often do, don't we, in talks like this, with a kind of definition. And this is an interesting definition. It comes from a Supreme Court case. I think not a particularly interesting case about grievous bodily harm or something like that. But I was quite struck by this bit of it in the judgment, which was, violence is not a term of art. It is capable of bearing many meanings and applying to many different types of behavior. And I find this a helpful way to start, because one of the things that I think that we often struggle with as psychiatrists is that many of the behaviors that we're invited to comment on or think about are seen in a kind of homogeneous way, that violence is seen as a kind of one single thing. Whereas I think, what I'm going to be talking about very much today is about the different kinds of violence. That's something I wished I learned much earlier on in my career, was the importance of thinking about the relationship between the perpetrator and the victim, and about the different kinds of violence that there are in societies like ours. And I'm going to focus, of course, mainly on a sort of British data, because violence is so different in different countries, and we can come back and talk about that later if you like. But I'm just going to draw mainly on sort of the stats for England and Wales in the last sort of decade or so. And most of the violence that we're concerned about, generally speaking, is interpersonal violence. And what's interesting about that is that violence rates have actually been gently reducing over the last 50 years, as far as we know, in terms of reported violence anyway. But we know that there probably are different kinds of violence that are unreported and unrecorded. But in terms of criminal statistics, violence is not the commonest kind of criminal rule breaking. The vast majority of people who break the criminal law do not act violently. Or put another way, it's actually an unusual way to break the criminal law to act violently. The commonest way to break the criminal law is a variation on nicking somebody else's stuff, whether you do that directly or indirectly and fraudulently or with threats, but the kind of personal violence that perhaps psychiatrists get involved in particular tends to be a quite unusual way for people to break the criminal law. And in terms of the statistics, the commonest kind of violence that police have to deal with are various kinds of assaults with or without a weapon, often either in the home or outside, plus or minus a theft motive. So I think it's still the case that the commonest type of violence is male on male drunken violence. But coming up very swiftly behind it are assaults within the home, mainly male to female violence. Homicides are a very rare form of violence. Sexual violence is a bit hard to know because of the underreporting problem, but sexual violence is certainly a kind of violence that interestingly, mental health doesn't often get involved in. And we might like to come back and think about why that is later. And then assaults on children. Similarly, people who assault children don't necessarily get referred to psychiatric services all that much. And again, we might like to come back and think about why that is. So I've got some data here for those of you who like data. This is just, again, just showing you something about violent crime, and over the last 20 or so years has been falling. And that's the same in other reasonably well organized social democracies. It's not the same in different countries. There are different countries that have different kinds of cultures, but the highest violence rates are in countries where the economics of the country is based on the drugs trade. But here, say in England and Wales, the rates of violent crime have been falling for a while now. So again, just to back up what I was saying earlier on, so in fact, this in 2020, the police recorded 1.8 million violence against person offences, which was an increase from the year before. So those are the police recordings, but 2.3 million adults reported being a victim of domestic violence, of whom 1.6 were women. So you can see that there's probably quite a lot of the difficulty about the stats with getting stats on violence is it depends on what kind of data you look at. Most of the data, there's recorded violence, obviously with police recordings, but there's the British Crime Survey, which is self-reported violence. And these, you can see there's the different kinds of violence: violence without injury, violence with injury. Stalking and harassment actually is interesting. That's partly, I think, because we have a new offence of stalking and harassment, which we didn't have before. Death by unlawful driving counts for 0.05%, and less than that is homicide. And that is completely average. That's an average year. The annual figure in England and Wales for homicides hasn't changed in 40 years. It used to be much higher in Scotland, but the figures, and of course highest of all for Glasgow, but I know due to all sorts of very interesting initiatives, I believe the homicide rate has dropped, but you guys can speak more to this than I can. And then you can see here that in children aged 10 to 15, only 2.6% were victims of a violent crime. So it's unusual for children to be victims of a violent crime. But of course, we don't know, this doesn't include all the physical abuse that's going on at home. And it also does include the sexual abuse that happens to teenage girls and boys. Again, this is just another slide showing the same thing. This is from a BBC production, but you can just see, it's important, I think, just to think about the kind of violence that happens with and without injury, because of course this makes a bit of a difference in terms of traumatic effects. But I think so it's just interesting to think about that. And I just wanted to put this in context, just to look at the homicide and suicide rates for the US, which you can see are a bit different. But even in the States, the homicide rate has been generally falling, although had a bit of an uptick recently. But even more worryingly in the States is the very significant increase in suicides, mainly in middle-aged white males. And there was a very interesting paper in JAMA Psychiatry last week about deaths of despair in the States, and the importance of looking at social and cultural factors in thinking about deaths of despair. So I've already touched on this, but I think that of the psychiatry of the violence that comes to the attention of psychiatry, probably most of the violence we see takes place in the context of some kind of relationship. Of course, if people make an attack on strangers without an apparent motive, then they will often be referred to psychiatry. But in general, violence towards strangers is generally less common. So they do tend to be a bit overrepresented in forensic psychiatry, because the assumption is that if you attack a stranger without any discernible, understandable motive, then there's an assumption that you might be mentally ill. But what I think is interesting is that psychiatry doesn't always get involved in familial violence. And again, I hope we might come back to talk about that. We do get involved sometimes, and of course, if it results in homicide, and most secure units will admit people who commit acts of homicide, often when they're mentally unwell, but often their victims are family members. And I've got a colleague in one MSU who I think his entire ward is full of people, of men who committed a homicide of a family member when they were mentally unwell. So, I mean, violence is very much a kind of a psychosocial phenomenon, and the risk factors for violence are largely social ones. So the general risk factors are being young and male and socially isolated, and having a previous history of violent crime, or being sort of generally antisocial. So one of the things that I tried to do in the book with Eileen was to set out an idea about violence in terms of different kinds of risk factors, a bit like a bicycle lock. So we might want to think of the general sociological risk factors for violence as being perhaps present in a lot of people. So there's a lot of young men out there, but only a tiny minority are going to actually be violent. And then when it comes to kind of social risk factors, we might want to think about substance misuse. We might also want to think about family relationships and adverse childhood experiences. Early childhood trauma is looking increasingly strong as a risk factor for later violence. And then we have the sort of individual kinds of issues, paranoid mental states, any kind of state of mind in which you have hypervigilance and poor reality testing. And then if you add substance misuse to that, then you've got a state of mind in which violence is much more likely to arise. But often the last number in the lock is something that a victim does. That's not, of course, to put any blame on the victims at all, but it's just that unwittingly, I think sometimes the victim may say or do something that has a very particular personal salience for the perpetrator of violence, and that can be the last psychological number that unleashes the violence. But generally, when we're assessing risk, we're ticking off the sort of general factors first, and the social factors, and then having a really good look at the individual factors. And obviously, from a point of view of violence reduction, what we as psychiatrists can do is going to be focusing very much on those individual factors. So this is just to remind us really about, this is about people who suffered non-fatal assault-related injuries. This is an American study from a few years ago now, but I just wanted to put it up there just to remind us that young males are also at risk of being victimized as much as young females. There are other studies which show slightly different, define different data. For example, there was a study published in 2010 looking at violent victimization and finding that heterosexual men and women tend to suffer roughly similar kind of rates of violent victimization, but the context is very different. So that women tend to suffer violent victimization in childhood and from partners, whereas men tend to suffer violent victimization as adults from other adults. And often they also suffer attacks with weapons. But this is just a reminder, really, to me, to raise the issue of the sex of people who are violently victimized, because I think the story that that women are principally the main victims of violence is not actually accurate. And this is from a study published in fact, just a couple of weeks ago, a very nice, one of these big meta-analytic reviews done by Sina Fazell in Oxford with one of his colleagues. And again, this is one about violence perpetration, looking at so this is a meta-analysis of all the studies that have ever been that are looking at the association between schizophrenia spectrum disorders, so schizophrenia in all points there on the psychosis spectrum, and violence perpetration. And I just wanted to flag up, because this is a nice slide, if only because it just shows you the interesting data about sex, about the perpetration by sex. Because although it looks as though maybe a few more women than men are victims of violent victimization, they're not too dissimilar. But when it comes to violence perpetration, men greatly exceed the ratio of the numbers of women. So the ratio of male to female perpetrators is grossly weighted towards men. And quite what that means, I think, is still not really very clear. Because I come back to the fact that the denominator of men who are not violent is huge. The numerator of men who are violent is small. Not all men are violent. But when violence takes place in the community, it seems that men tend to account for at least 80% of the perpetrators. I thought it might be helpful to just look at a kind of ecological model. This is a model first postulated by Bonfenbrenner in the late 1970s. And this is an attempt to look at sort of micro level factors and macro level factors again. And I think that is a really important way of thinking about it. And it has, of course, significant implications for those of us who work in forensic settings. So we know that there are micro level influences in terms of genes, and although genes really only exert an influence at the level of sort of the building blocks of arousal, and there are no genes for violence per se. Attachment and attachment disorganization definitely looks as though it could be a risk factor for violence. And there was a meta-analytic study published in 2014 which suggested that insecure attachment is a risk factor for violence. Family values, beliefs, cognitions, these turn out to contribute something, I think, to beliefs about violence, and beliefs about who is a kind of what violence is used for and when violence is justified. But at the level of community, there may be some very important cultural beliefs about who is a legitimate victim of violence and what kind of people is violence sort of normal for. And that bleeds, I think, into cultural policies and laws and beliefs about the use of violence. So I think it's helpful just to think about the combination of micro and macro factors. And of course, mental illness will be operating at the level of the individual. But I do just want to flag up this issue about male gender role, because one of the questions must be whether masculinity and various kinds of narratives of masculinity somehow contribute to an increased risk of violence. Clearly in different cultures, there are different tolerances of substance misuse, tolerance of violence, access to weapons, of course. One of the other interesting things is at the level of the state is income inequality is typically associated with high rates of homicide and suicide. So if we just think about the mental states that increase the risk of violence, because this, of course, is where people like me are going to be coming in first to do assessments, help courts decide what to do next with this person, and then maybe offer therapy. then we need to look at what kind of violence this is. For me, working out whether this is relational or non-relational is always my first step. Was there a relationship with the victim or wasn't there? And then really looking at the different states of mind that the perpetrator was in at the time. Are we talking about an affect-full kind of violence or an affect-less kind of violence? Are we talking about something that's controlled, or is it impulsive? Again, clear in the perpetrator's mind or very confused. Excited and aroused or detached, watching from a distance. And then a time-honored distinction, which is about proactive or reactive. Where proactive, whereas the idea you plan violence for an instrumental purpose, whereas reactive is kind of more defensive violence. Where, and this is something that comes up quite a lot, of course, with patients who act violently, who will often say, at least, that they reacted violently because they were frightened. And of course, if they're paranoid and they're high and drunk and so forth and experience lots of trauma, then that may well be right. But of course, these things may not be alternatives. That's the other thing. I think when it comes to proactive or reactive violence, they may not be alternatives. And of course, people's states of mind shift. And what they say after an act of violence may not be what they say before. This is from the UNODC report, International Report on Homicide, published in 2013. There is a more recent one, but this is one of the nicest images that I know, just to set out very nicely the different kinds of homicide, because they are not the same. Someone who kills an intimate partner or family member is not the same as someone who kills in a gang for organized drugs, for drugs in an organized way, for criminal acts. Which is not the same as killing in a socio-political context. And I think this is really important when we come to think about risk, because it's, you know, the idea that all homicide perpetrators are the same is to ignore the kind of motives for their offences. So, but do violence perpetrators have anything in common, given how diverse they are? Well, my experience is that at the ultimate moment, there often is a kind of disturbance of reality, in the sense of sort of a personal sense of reality, things often not seeming real to them. The victims often don't seem real to them. Often their sense of their social reality has become quite disturbed, often feeling they don't belong, or, you know, their lives are over in some way. I think it's very common for violence perpetrators to have threat perception problems, to have a low threshold for threat perception, and that may well be to do with unresolved trauma. This kind of disturbance of social connection to other people, so that other people don't seem real or human, is something that a lot of violence perpetrators say. That at the time when they were attacking or killing their victim, they didn't really seem real or human. Very interesting absence of consequential reasoning. It's very rare in my experience for violence perpetrators, particularly fatal violence perpetrators, to have given any thought to what happens later. Occasionally we see them, you know, people who've made a bit of a plan for covering it up and so forth. But generally speaking, those people don't come the way of psychiatric services because they're thought to it's thought to be ordinary violence. And again, you can see the kind of circularity here. But I must say, I'm very struck by the people I've seen who've killed other people, that they don't really seem to have thought about it, what will happen next. And often there's something here about nothing will matter because this is real. And then finally, obviously, a lot of violence perpetrators have a wish to hurt, wish to inflict pain, a denigration of vulnerability. When somebody's vulnerable to them, that brings a kind of excitement and a kind of wish to control and shame and denigrate that vulnerability. Not all perpetrators of violence can admit this, and it often takes people a long time to admit how pleasurable it was to really cause somebody else pain or bring about their death or damage them in some way. So again, just to come at this another way, people who are violent often will describe others as a threat, but sometimes we do meet the odd person who clearly has this kind of controlled predatory state of mind. But even they will often describe little sense of agency. It's very common for violence perpetrators to describe very little sense of agency and feel that they were justified in what they were doing, that they were being acted on by other people. And they have to overcome their various inhibitions to violence. And that's often where either a justification will be useful or substance misuse will be an issue. But it's not at all unusual, therefore, when you first meet someone who's committed a serious act of violence, for them not to be particularly anxious or not to be particularly worried, because often in the first days, months, weeks, months, sometimes they will be very stuck in their narrative that actually what they'd done was entirely reasonable, and they don't want to think about it. And they certainly don't want to think about it anymore. But this is important not to confuse with remorselessness or callousness. Sometimes this is still about being a kind of slightly dissociated, detached kind of state. So this seeing others as a threat is clearly a big issue. And this usually goes alongside an inability to mentalize really painful emotions of rage and fear, hatred, shame is another one. And then projecting those feelings onto other people and then attacking them in the other person, in the victim, is often a good way to empty yourself of those kind of feelings. Sometimes a victim's consciously expressed anxiety and vulnerability will generate panic and attack feelings and hostility in a perpetrator. We see that quite a lot with children, particularly women who attack children. And for those people who have been abused in childhood, typically physical abuse and neglect have very strong associations with later violence. And naturally, the sense is that there may have been some unconscious identification with the person who hurt them, particularly if it was a much-loved parent. So again, seeing others as prey is likely to be associated with an inability to tolerate feeling needy or vulnerable. But I think there's, again, a very interesting question culturally about where those societies where vulnerable people are typically denigrated, where there's a kind of general public narrative about the denigration and derogation of vulnerability and weaknesses as others, which is one of the reasons that I have particular anxiety about the depiction of women as victims, because I think that there's a kind of unconscious message that that's really what women are like, is that they're just victims of violence. I have almost never met any violence perpetrator who said, well, there was no reason for me to do what I did, wasn't justified, I did a bad thing. Most people, when I meet them first, at least, have a self-justificatory narrative at the beginning, at least. And in a way, it's a bit chicken and egg, you see, because the self-justificatory narrative, you need that to be in place in order to do it. But often that's associated with quite rigid moral thinking, typically an absence of kind of forgiveness. A lack of empathy reduces your anxiety about violence. And anybody who's been raised in strict dominance hierarchies will probably feel that inflicting violence on somebody more vulnerable may help to promote self-esteem and reduce a sense of shame. And again, you can see how this might play out in certain cultural and ethnic and religious groups. So after the violence, some perpetrators will talk about a sense of peace, a sense of relief, but some will talk about a sense of shame, a bit like addicts do. Many in the first days and weeks will have a kind of amnesia for the violence or be quite dissociated from it in patchy kind of ways. As I said, denial and minimization are commonplace. And I think what's complicated about that is that, of course, is operating also at the time when people are running up to having a criminal trial. So it's we try whenever possible as forensic psychiatrists, and this applies particularly anybody who's working in a prison, we try very hard not to engage with people before they've had a criminal trial, because people must be allowed to run their criminal trial the way they want to. And it's usual for most perpetrators to be advised to plead not guilty and to say that they're innocent. And that story will often change closer to the trial, but it's complicated. But we worry quite a bit about despair. Despair often sets up a stimulus for a next attack, and that's particularly in domestic violence. And I don't know how many people, any of you have seen the wonderful Joel Cohen Macbeth. And I thought of this particularly, of course, because I was talking to you in Glasgow. But here, as Shakespeare so often does, anticipates the forensic psychology by several hundred years. I am afraid to think what I have done. To look on't again, I dare not. And that absolutely sums up many of the people I work with. They are afraid to think about what's happened. And they have to feel very secure. It takes certain courage to be prepared to look at that. Post-traumatic phenomena of violence perpetrators. This is now well described in the literature, partly in relation to the violent offense itself. So we have a steady percentage of people who have PTSD symptoms because of the violence that they perpetrated. That's something that you particularly see in people who've committed violence to family members, but not only. And of course, we see people who have post-traumatic phenomena that goes back to their childhoods, but it's often very difficult to parse out from all the other phenomenology that's going on. And that childhood trauma often manifests it most in terms of the language that people use and the passivity and helplessness with which they engage with the world. But naturally enough, if we do have people who have active PTSD in relation to their index offence, then that's a very important thing for treatment planning later. And this is really just a reminder to me, that how complex, the neuropsychiatry of this is. I mean, that in terms of trauma and the trauma of having committed an offence, as well as the trauma of having been a victim of violence oneself. Wanted just to touch a little bit on people who've grown an antisocial mind in their late childhood, early young adulthood, because these are the young people that we worry about most. As you probably know, criminal rule breaking and violence generally is basically an activity of the young, and a startlingly large number of young people have broken the criminal law in some way. A slightly smaller group have been violent, generally to other young people. But there is a subgroup of young men who are violence persisters. They go into a trajectory where they escalate from being criminal rule breakers to being violent rule breakers. They get into trouble with the criminal law early. They're criminally violent throughout their teens, and they graduate into the adult criminal justice system. And these are called violence persisting trajectory. And these young men often have a profoundly antisocial state of mind in which they really lack a sense of connection with other people. They have very poor affect regulation, and so they act without thinking, but they also have some thinking without feeling, and often a fragmented and unstable sense of self. And none of this is good if you're taking a whole load of various types of intoxicant. So, lovely quote from Marilyn Robinson, which I like, I think, because in the work that I do as a therapist with violence perpetrators, I think quite a lot of the early work we do is about getting people into a state of mind where they can be comfortable thinking about their own minds, which for many of our folk is a long haul. Many of our people have not been able to grow a secure sense of self at all. We see people who are genetically vulnerable. We see people who've had highly insecure and disorganized attachment systems. We see people whose carers when they were children, they had carers who were hostile to them, or who just ignored them and just neglected them. So we know how important the carer's mind is in terms of providing the environment in which epigenesis will take place. And we know also that communication is crucial to developing a secure sense of self. And many of the people that we meet in forensic services have never really developed an emotional kind of literacy or an emotional lexicon. Or they experience, if you don't like the word suffer, they experience very significant alexithymia in terms of the ability to put their feelings and thoughts into words. So abuse and trauma in childhood is very common in violence perpetrators, and particularly in people in prison. A study of violence perpetrators in HMP Park found that something like 80% of them had experienced at least one kind of childhood adversity, and 50% had experienced 4 or more kinds of childhood adversity. These were all male prisoners in Park. And as you probably know, the experience of 4 or more kinds of childhood adversity puts you at significantly increased risk for both poor physical and mental health. So we have increasingly good evidence that abuse, probably when we talk about abuse, we're really talking about consistent and persistent fear experiences in childhood over a period of time, causes attachment, disorganization, and that leads to poor mentalizing, poor thinking skills, the inability to read or read other people's emotional cues or your own emotional cues. So what people do very naturally, they're stuck in what Alan Shaw talked about, they're stuck in a kind of right brain parasympathetic level, where that's where all their feelings and emotions are. So they act out, they use their bodies to express emotions. Somatic symptoms very common in forensic populations, as well as obviously the violent acting out that got them into our services. They often have very poor sense of self-boundary. And although this idea of responding negatively to image in a mirror comes from quite an old study now of abused children, I think that this would be a very interesting thing to study in adult perpetrators. I strongly suspect that many of our people in the forensic settings respond negatively to their own image in a mirror. And I think the way that it might work is that for people with highly insecure attachment systems, that the moment they feel needy or vulnerable, that stimulates intolerable anxiety, an increasing sense of arousal and fear. But as their anxiety and arousal soars, they become physically uncomfortable, but they can't mentalize to make themselves feel better. And their reality testing begins to deteriorate. Substance misuse further affects that. And then into that state of mind wanders the victim, who says or does something that then makes it intolerable, and the perpetrator then acts. Plenty of studies to show that insecurity of attachment is higher in forensic populations than the general populations, particularly avoidant attachment. But we think that enmeshed and anxious attachment may be particularly relevant to some kinds of relational violence. And that's a really good example of what I mean by you have to really analyze the violence, what happened between these two people. And David Cantor, who some of you will know as a criminal profiler, very interesting professor of criminal psychology, published a book about 25 years ago in which he suggested that we might want to think about violence as a transaction. And I think that's a really helpful way of doing that. But enmeshed attachment, as opposed to dismissing or avoidant attachment, very common, for example, in battering men. But we have these other risk factors we need to think about. I've already touched on this, and I'm sure you know all about it. But I think it's really just important to remind ourselves that you can suffer 4 kinds of childhood adversity without anyone laying a finger on you. You could suffer from neglect. You could suffer from growing up with parents who are incarcerated, who are mentally unwell, witnessing domestic violence, parents who have substance misuse, and very acrimonious divorces, which usually follow on from the witnessing domestic violence. If you have all of that and you're also neglected, you've experienced a big amount of childhood adversity without anybody touching you. And I just really want to emphasize that, because we have become rather focused, very naturally, I think, about those kinds of abuse that involve physical touching. But actually, I think when it comes to forensic violence perpetrators, we need to be thinking about these other things as well. And this comes from a study of juvenile offenders in a Florida prison. So the blue bars are an HMO, That's people like us, and the brown bars are the young men in the Florida prison. And again, this is an adverse childhood. This is an ACE score study, and you can see that nice people like us, about 35% of us have experienced no childhood adversity at all. And that's a very interesting group of people, by the way, about which we need to know quite a bit more. That a few more people have experienced one. But when it gets to 4 or more kinds of childhood adversity, you'll notice that very few members of the HMO had about 10%, and that's a finding across the globe. About 10, 11% of people in the general community sample have experienced 4 or more kinds of childhood adversity. But you go into a violence population, and you find exactly the same in this study as they found in PARK, which is that 50% of the young inmates had experienced 4 or more kinds of childhood adversity. So going on to treatment, well, I think we have to acknowledge that there's a philosophical and sociological question about whether the language of treatment is the right word, because clearly violence is a public health phenomenon. Many sociologists have invited us to treat it like this, and not just sociologists, some physicians as well, A&E physicians. Some of you will know Jonathan Shepherd in Wales, who pressed for many, many years to make violence a public health issue. But I guess within the world I work in, we are treating, if you like, the underlying mental states and attitudes. And we think about risk as a continuum, not a state. So we think of people as being able to move from mild to moderate to high risk states of minds, and hopefully moving back again as well. And the advantage of therapies is that we can use our therapeutic relationships to help look at the interpersonal context of risk and understand a bit more about people's attachments. And the other thing we do is to offer a lot of group work, because groups are themselves a very powerful embodiment of the pro-social, of belonging to something, and they stand as a kind of challenge to the antisocial state of mind. If we can get men to join a group of any sort, and that's sometimes a big if, but if we can, that in itself is a big pro-social step, and it makes a big difference to people. We do use medication a lot, but it should always be adjuvant to psychological approaches. And of course, there is no medication that stops people being violent. But what we really want to do is give medication that's going to boost that pro-social state of mind. So we want to decrease fear, decrease arousal, decrease agitation, and clearly increase capacity for reality testing, which is, so for those people whose reality testing is poor when they get agitated, then clearly, the various antipsychotic things that we give often make a difference, and often help people to get engaged in therapy too. But we have a real issue in forensic services about symptom suppression, and a kind of reliance on institutional good behaviour as evidence that people have made progress. And we might like to come back to that later. So we have different interventions, different settings, different stories. So here are 3 kinds of Jim. There's Jim, who's 42, homeless, drug user, socially isolated, kills 2 drug dealers while he's paranoid, gets a life sentence. He's got a tariff of a 24. The Jim I'm thinking of in this vignette, he got a 24-year tariff on his life sentence. He won't be released until he's 70. Second Jim, 42, develops morbid depression with somatic features, kills his elderly father with whom he lives. Despite there being quite good evidence that he was mentally unwell at the time of the killing, he gets convicted of murder. In fact, this one, he did get convicted of murder. He got a life sentence, but with a shorter tariff, acknowledging that he was mentally unwell. And then there's Jim, another Jim, 42, killed his mother during a family row, claimed he had autism during the trial, despite having no history of dysfunction of any sort. In fact, was a successful professional. And he successfully ran a diminished responsibility defense and got and was detained under section 3741. So you can see here are 3 kinds of man, roughly the same age, all commit a homicide, but in very different contexts, in very different circumstances. And the responses of the institutions in which we work are different. So there are prisons, there are secure psychiatric services in the communities, and the violence risk in the presentation is going to be different in different contexts. So if I'm looking after the last Jim who killed his mum, my approach to how I'm going to be working with him and formulating his violence might be a bit different to the Jim age at the top, who's, who killed while paranoid, got his massive life sentence. And the Jim at the top I met because he went mad in prison and got transferred to our hospital. So, and we think quite a lot about psychosocial approaches. And I think really forensic services, this is the way that forensic services have to go, a much more emphasis on the prosocial and the existential. And I say existential because I think it's important for us to remember, I've come to experience this anyway myself, that when I'm meeting a man or indeed a woman, I meet them at a very particular chapter of their lives, and their index offence has changed everything for them. Often there was life before the index offence, and now there's life after. And I think it's really important to keep that narrative, existential narrative, in some kind of perspective, keep it there as part of formulating a treatment. You need a good formulation, and you particularly need an articulation if you can, and sometimes it takes a while to get there, which is why the therapy with perpetrators of violence takes a long time. You really want to try and help them articulate that part of their mind that wanted to hurt and intimidate others, or how other people came to be seen merely as a means. And I think as therapists, what we're doing is trying to offer a kind of matrix of trust and security where therapy can take place, but without providing an excuse or forgiveness. And that can be really hard, because people often want both excuse and forgiveness. And that, of course, is not ours to give. So what we also focus quite a lot on is trying to help people take a bit more ownership over what they did. So often people will talk about the old me and the new me, or that was the false me and the real me. And there's some very interesting work by Emma Baldock about agency and capacity to take high-cost decisions, and whether you need a truer sense of self or a high-cost decision. Now, the thing is, deciding to kill somebody else is a pretty high-cost decision. And what kind of authenticity or agency do you need for that? And I've been very influenced by the work of Shad Maruna, who's professor of criminology in Manchester, who's done some very interesting work on desistance and agency. And I think there's something there for us as therapists with violence perpetrators. So this idea that there's a kind of reworking of narratives of passivity into narratives of agency. And it often really involves an acceptance of the offender identity. And it's really only when people can accept that they did what they did that they can start to think about developing a more prosocial state of mind. So often it starts with, well, it wasn't me, I didn't get hurt. And then it moves to, well, it wasn't me, but it was my illness. And then I was ill when I did it. And then actually I killed her. And this progression is something that Murray Cox, my predecessor at Broadmoor, this is his example, and it's a beautiful description. And I've seen that play out in therapy, where people gradually move to be able to take more ownership. So what we don't do as therapists, forensic psychotherapists, or working with offenders, we obviously don't tell them that they're bad people and they ought to be ashamed of themselves. Although I think some of the nursing staff sometimes find themselves in states of mind where they just feel so frustrated and pissed off and hopeless that they can sometimes say things like that. And of course, the patients say it to each other sometimes. We try very hard not to tell people what to think and what to say. We try very hard not to assume that we are always right and have the only true narrative about what happened, but equally we don't assume that everything that the people we work with say is true. We understand that what they have to say is true from their perspective, but we're always working at it as a kind of working narrative. And as I said, we can't offer them an excuse. Even when they've got diminished responsibility defense or get a 3741, even then, most of the people I work with know very well that there was a part of them that is responsible. and it's very important, I think, to support that part of them. And as I say, I have met many people who clearly long for somebody to forgive them. And the urge to say something forgiving is sometimes very strong. And it feels unkind not to do so, but I think it's very important that we don't. So the therapy really, if you're going to do therapy with offenders, you need to make sure you've got a secure base, a secure psychological base, as well as a kind of secure physical base. It doesn't have to be high security, but you need somewhere that is going to be consistent and predictable, and where you as a therapist aren't going to be worried about that. And it needs to be safe enough to encourage somebody to say something that's hard to say, and to acknowledge the kind of tragedy. You have to be very careful about reenactment of toxic attachments. And this is where absolutely traditional ideas about reenactment of old trauma, or say recapitulation of toxic attachments. But you can use a variety of media or techniques. We've often found that it's helpful to start people off with some cognitive techniques to help them get used to thinking about their own minds and observing their minds. And then we move them on to something, often some group skills, some DBT skills, sometimes quite helpful. Schema can be helpful. But then before we move on to more reflective kinds of technique, we need to be able to know that they're going to be able to manage their arousal if they feel something sad or angry or upsetting. And of course, the non-verbal therapies can be extremely helpful here. So we have great occupational therapies, not nearly enough of them, but we have great OTs, and we have some arts therapists as well. And we make good use of them whenever we can, because those non-verbal therapies can be really important for helping people find a language of emotion. And as I've already said, we utilize group therapies wherever we can, because it's harnessing the pro-social tendency. And it actually, paradoxically, can be quite good for people who are very anxious. They can sort of disappear a little bit in a group. And similarly, people who are full of shame, it can be very helpful to put people in a group with other people who've done the same thing. And this is a quote from the homicide group, somebody who was leaving the group, in fact, and to go on to another secure unit. And he said, "I imagine this group will go on forever. Maybe in 200 years, it will still be going," which I thought was a rather amazing observation. And here are some other quotes from groups. This is from a group for people who were leaving the hospital. "Not having a structured day is a killer." It's a memorable quote. "I'm worried about this form I have to get. It's my P45 or something like that." I thought what it must be like about whether being in Brauma is a kind of job that you need a P45 for. "I'm fed up with myself. I don't want to be me. I want to leave that part of me behind. I'm living in hope of freedom from my mind." This is the kind of fragmentation that I think a lot of mentally ill violence perpetrators struggle with. How are we doing for time? Have I got a minute or two just to?
Yes.
Yeah. Because I've just got a quote from. I've got some quotes from a man who was in an MBT group that we ran for violence perpetrators. And we did the adult attachment interview with these guys before and after. So as part of the adult attachment interview, we asked people about childhood disruptions, and in this case, it's parental divorce. So the guy is asked, did they divorce, about his parents? And if you just read it for yourselves, you can see, well, this is a transcript of what he said. "Well, I don't know if he divorced her or not, but all I know is that he left her in a sense that he told her about his companion, as he called her. And then, to cut a long story short, I blamed him for her demise because the last flicker of flame in her belly had been extinguished." So this is the kind of language that we often hear at the beginning of treatment. You can pick up kind of, it's reasonably, you can understand it, it's comprehensible in what he's saying, but there are kinds of pockets of incoherence in it. I don't, this is not a comment on his prose or anything, it's just some things don't necessarily hang together, and you wonder, we don't know who this companion is, and he moves from talking about the companion to her demise. So there's something about moving from the divorce to a death, and then this very intriguing metaphor about a flicker of flame, which is beautiful, but it's very hard to know what it means. And then the interviewer goes on, well, what did she do when she heard, picking up on the last coherent thing I think that they could hold on to. And then he said, well, of course, after being married to him since childhood days, see aunts and all the rest of it, you know, from back in the army days and all the rest of it. And I thought, well, he's responsible for her demise. I was just grieving so much I didn't know what to do, so I thought I would kill him. Probably glad he wasn't in, really. He wasn't in, so I got him through the back door at the side of the house and went to go and hang myself in a tree, but that didn't work, so I left. So this is a man, again, you can see that he doesn't answer the question. What he does is go off into a kind of very interesting return to this issue about how he thought his step-grandfather was responsible for his grandmother's death. But you see, he moves very swiftly from her death to thoughts of killing him. I was grieving so much I didn't know what to do. And then, so he thought he would kill him, and he can't kill him, so he thinks about killing himself. So you can see, again, it's comprehensible that there's a kind of incoherence to this narrative, which is very typical of many violence perpetrators with mental illness. And here he is 18 months later, having had 18 months of therapy, and he's being asked about the same thing. He's being asked about his grandmother, and he goes on to say, well, I almost had a breakdown. Well, it is a breakdown, you call it a breakdown. First of all, I went to harm my granddad because he'd taken on a companion, and I'd found out before this, he told my grandmother while she was in hospital that he couldn't enjoy his retirement. My mother knew this. Why has he done this? She said, I don't know. My grandmother died. I went to confront my grandfather with the intention of harming him, probably killing him actually at that time, and it wasn't him. Luckily for me and for him, I don't know what I would have done if I got there, if I'd actually carried it out. Obviously, I was very upset. I was really grief-stricken, and I tried to hang myself in the garden. I broke into the garage and got some rope and tried to hang myself. And that is what happened when someone dies. I'm not talking about my index fingers. I'm talking about as a child. And I hope that you can see that much of the same material is covered in his answer to this question, but it has a kind of slightly more organized timeline, and it contains much more self-reflection, much more explanation of why he was thinking the way that he was doing and why he took action. We don't have any slightly odd metaphors, and we've got something that's a bit more understandable. The thing that's, I should say straight away that this patient very kindly gave me permission to use these excerpts to share with other people, and I'm very grateful to him for doing so, because it's really is a beautiful example of the kind of little linguistic shifts we look for when we're working with people. The other thing I should say is that this man had actually been convicted of killing a stranger in the street when he was psychotic. And we found ourselves wondering whether the unresolved issue with the grandfather had got displaced onto his unfortunate victim. So can people refuse to have therapy? Could we force someone to become more pro-social? Does the state have a right to insist that you change your mind about your life and the way you relate to other people? Is it justifiable to withhold goods and liberty if people fail to make such a change? Do we have the right to be antisocial? We're prepared to take the consequences. And these are some of the questions that come up very much in prisons and high secure settings, I think, where we meet people who sometimes just don't want to engage in therapy, don't want to think about it. Often are very angry, stuck men and women. And what do we have, what can we, as a large group of community, what rights, small r rights, perhaps, do we have to ask people at least to think about changing their minds for the better? So I'm going to just stop there. I'm going to suggest to you, argue very strongly that violence is not homogeneous or normal. It needs attention, it needs explanation. We need to look at all the multiple risk factors that increase violence risk. And we need to be really careful with assumptions about motives for violence. They're rarely single or simple. And my final thought really is that if we're going to deprive people of liberty because they've been violent to others, which may well have to be the case for all sorts of reasons, do we have a duty to help them? Do we have a duty to try and help them change their minds for the better? So I'm going to stop there.
Okay, well, thank you very, very much there, Gwen. Oh, thanks for getting the screen back. That was a wonderfully rich and strangely moving presentation, I found. But there's lots of questions, I suspect, and the first off, Gordon has got something to ask.
Thank you. Wonderful, echoing what David's just said. Tempted to ask about ADHD, but I'm going to put that aside and ask a more sort of philosophical question. I was quite struck by you saying that it's not our job to forgive people, and absolutely. But is it our job also to open up a space where people can engage with what they've done in a way where they can move to a place where that's maybe not unreasonable to think about? I often talk about the medieval theological idea of the compunction of guilt, the pricking of guilt, which is asking us to engage. It sounds better in German, Auseinandersetzung. And if we're doing that and we're allowing the prompting of our sort of deeper or of our authentic self, which with Lady Macbeth came out in the, she couldn't get away from that. That's there. If we're engaging with that depth, is it not then reasonable to be opening up a space where people can be forgiving of themselves if that prompting of guilt has created a change of mind from the change of mind which characterized what they did at the time?
And forgiving themselves, absolutely. That's not the problem at all, and nor, of course, is attempts at restorative justice, which we have in our hospital, and most prisons have attempts at restorative justice, and obviously, and I would say that any therapy we do would be encouraging for people to try and get engaged with that if they can. What I was really thinking about is I've certainly been in groups where it was very clear that people were just longing for somebody to say it's okay. And it's just not possible to do that. But for them, and often what we would do in those circumstances is to say that, it's just to articulate that, is how much people, perhaps you, Jim, want to be forgiven. And that would then often allow other people in the group to say how much they want to be forgiven, how helpful it was when they've been forgiven, and how will they ever be forgiven. And then people can talk to each other about that. But actually the other people in the group taking that up and running with it, exploring with it, that all makes perfect sense. I think sometimes, though, what there can be is there's something about, looking to the therapist to offer something which and it can be quite seductive, I think, in people who are tormented by guilt, and not just guilt but also shame and such terrible sadness, terrible sadness. Who's going next?
Who's going
David,
next?
You're in charge.
I'll try to be. I think Ian had his hand up first, and then Mark. Ian, you're muted.
If you could hear me, it would help if you could hear me, right?
There we go.
Yeah, no, I was thinking of your kind of pro-social idea, but then my mind's wandering to the Usman Khans of this world, who seemed to be rehabilitated and then killed those two people near London Bridge. And of course, he went through some kind of therapeutic process to renounce his extreme Islamic views and that violence was justified in his cause. And it makes me wonder then, is it a tricky question for you as a therapist to know if someone's apparent change is in fact authentic?
Absolutely.
Yeah.
Absolutely. Yeah.
And how can you sense that or tell? I mean, we're Machiavellian creatures, and if you're going to get out of prison earlier, you're going to say the right things, I would have thought, but is it genuine or not?
Well, I mean, it does depend a little bit on the context. I think in high secure hospitals, what's rather amazing is how rarely people say the right thing. Actually, it's constantly amazing to me how often our guys in Broadmoor do not say the right thing at all. But I think in the prisons it's different, and I also think that terrorism is a different ball game. Now, of course, I'm not working with terrorism because I'm mainly working with relational violence perpetrated by people when they're mentally unwell. I'd have assessed people who've been involved in terrorist violence, because they end up having these kinds of assessments, but they don't come to mental hospitals because terrorist-related violence is not seen as being related to mental illness. But what they do have, as you rightly say, are these de-radicalization programs in prison, and as you rightly say, their efficacy is moot. There's lots of very mixed data about it. But I think that worldwide, most people who work in prisons have thought it was better to offer something than nothing. But you have to take that step. Release decisions from prison, these are really tough decisions, which thankfully I don't have to take. They're tough. Who'd be on the parole board? They're tough decisions. They're really tough decisions. And that was a particularly sad and disturbing outcome.
Thanks.
Thanks, Mark, and then Alistair.
Thank you. I was just thinking about the illustration of the comment from staff to the person, "You ought to be ashamed of yourself." And I suppose I was just wondering about that response, and being interested in the idea of a kind of shameless state of mind that might precipitate such a response in a way, and wondered if you had any thoughts about shamelessness. And probably connected with my questions is something about being quite struck in the cat in the political world about shamelessness.
You've been eclipsed.
Yes.
Yeah, as usual.
Wants to join in. Well, two very interesting and different contexts, Mark, of course. I don't feel in a position to make any expert comment on rule breaking by people in positions of power. But I think what I was trying to get at, I suppose, perhaps not very helpfully, was just something about how difficult it can be, or how different it is for therapists working with violence perpetrators in secure settings. That how different my role is. And even if I'm an RC, if I'm running a ward and I'm the consultant in charge, even that role is very different from the nursing staff's role. The nursing staff who are sort of permanently on the wards, day in, day out, long hours of shifts with people who are sometimes very difficult. And I think because our secure settings, both our prisons and our secure hospitals, do tend to run as dominance hierarchies, in which the prison officers stroke the nurses have to keep control, have to be the dominant group. And I think that can lead to kinds of adversarial tussles in which the patients can sometimes be hostile in an attempt to bolster their own self-esteem and to feel a bit more, I don't know, kind of agency, and perhaps to reduce a sense of shame, I think. And I think that sometimes the nursing staff just gets, sometimes the patients will complain or be demanding and will be asking it over again, or tell the nurses that they're useless, and or even just be frankly abusive to them. And then the nursing staff, HCA, they'll lose it. They'll get angry. And one of the jobs that we have as therapists in secure care settings is trying to support the nursing staff, I think, with the very difficult role of nursing people who are sometimes very difficult to look after, very difficult to live with. But the shameless state is interesting, and we do see that state of mind, Mark. I think we do. We quite often see it in people at the beginning when they're first admitted to places like Broadmoor. But often that kind of shameless is a kind of defense against feeling very shameful. It's a kind of bravado. I don't care, you lot are useless, it's all a load of not. I mean, we do get a bit of that often at the beginning, but then often there's a dreadful collapse later on, particularly after the trial. So, very interesting question.
I'm tempted to put a comment in there, but I won't, not until the end. Alistair and then Leonie.
Thank you very much. That was a really interesting presentation. Before I come to question, I just need to quickly say hello to Dr. Barkley and Dr. Smith, your previous supervisors. It's been a long time. I'm a higher trainee in intellectual disability psychiatry, and I know a large proportion of people in the criminal justice system might have an intellectual disability, or at least a borderline. And I was really struck at the start of your presentation by a lot, I don't know if shared risk factors is the right term, but a lot of overlap there in terms of underlying reasons for violence. I'm just interested in terms of how much the sort of challenges you might have faced, and how much success you've had in terms of treating people with maybe a mild intellectual disability with sort of a psychotherapeutic approach.
Well, I was lucky early on in my career to meet and work a little bit with Valerie Sinison, who, as you know, was a pioneer in psychotherapy with people with learning disability. And that was really, her experience and her teaching was really important to me, because clearly, as you say, most of our folk are certainly borderline in terms of learning disability, although in my experience this is nearly always attributable to long-term childhood trauma and also the fact that they weren't able to get into or stay in school. So they've usually missed out on education rather than actually having any kind of significant learning disability and the kind of sort of organic kind of impairments. And so what we try and do is we try and modify our techniques for them. But that's what I took away from working with Valerie, is that, there's no, in terms of affective learning and self-reflection, this is a communication issue, and it's our job to be communication friendly. But I wouldn't want to sell people short either. I think there can be it's very important, I think, not to assume that people can't do things. It may well be, particularly if you put them in a group with other people and just not pressurize them too much, that they may be able to catch up or join in a way that works for them, because what they have to say will be what they have to say for them. And so I think that I think it's not at all unusual, but I think it's very hard to know what it means in forensic settings where you've got people with a borderline sort of IQ of 69. What does that mean? Whole other discussion.
Indeed. Yes. Leonie.
Hello, Gwen. I enjoyed your talk so much. So enlightening. The only experience I've had in forensic areas and training in Perth prison a long time ago.
Interesting.
But my curiosity was around, your comments about we can't really force people, can we, to have therapy in the real sense? But yes, in this kind of microcosm of, in this enclosed place, I mean, I'm just wondering about the dynamics around people joining groups particularly. And I can see how there's so many therapeutic ingredients in the process of a group. and how valuable it must be, like you've been saying. And I just wondered, just on the ground, do people join sort of readily? Do they maybe join after a while, or is there a peer sort of thing that goes around that says, yeah, it's good? Or just my curiosity was
yeah, no, it's a very very good question, and a lot of thinking about planning therapy is about the timing of it and what kinds of therapy might go when. But we often find that people actually find individual work quite overwhelming, and so small groups which have a kind of task focus can be really helpful for getting people used to the idea of being in groups. But we do get people who are who are anxious about them. Of course we do. And the other thing is that, I mean, when I came into this work, you know, I'd done some training as a sort of general dynamic psychotherapist, and it was put to me that, you know, this kind of approach was not suitable for people, you know, who, you know, had very little schooling, weren't very articulate, who were violent, that they wouldn't be able to sort of get it. And so my experience listening to Valerie talking made me think, well, that can't be true. I don't think that is true. But I think what we have, I mean, I think, of course, it's fair to say that a lot of our guys are a bit suspicious of groups. Of course they are. So we often spend quite a bit of time, you know, it often does take quite a bit of time to get people to a place where they feel ready. And we obviously don't force them. But we do rely quite a bit on peer information. And I think also just trying to model, we've been trying to have ward-based reflective groups, particularly in the pandemic, where people can, again, get used to the idea of sitting and talking to each other as people. I think just sitting and talking as people, maybe if it's just about the football or maybe what they want on television, but just the idea of sitting and talking to each other as people, asking about people. The other thing I've learned is that ambivalence is not a bar to therapy. You know, that naturally people are going to be ambivalent. You know, that in a way it would be odd if they weren't ambivalent, and rolling with that a bit. You know, and if people don't come, you know, maybe they don't come 50% of the time for the first 6 months. Well, that's okay.
Yeah,
we'll roll with that. You know. Just being understand. I think it's kind of taking up a kind of empathic stance about ambivalence. Most of us are ambivalent if we were asked to think about the worst thing we've done and the way it's changed our lives. I'm fairly ambivalent about talking about that. So yes, I think
I'm just imagining that for a lot of people it might be quite a new sort of cultural experience to sit and talk about anything, even ordinary things.
Yes, absolutely.
That would not be it would be a novel experience just to do that. I'm just imagining.
Yeah, absolutely. Having and there's a bit of a tension, and this is true in prisons and secure hospitals, about whether you can be friends with the other guys. I think friendship is something that many of our folk don't know very much about. And that great pleasure that friendship is, I think very few of our guys have that kind of experience. And so trying to help build the building block, create the sort of building blocks of what a kind of friendship might look like, is interesting and not without its problems.
No, that's very helpful, and it's what I suppose I imagine that it would be a new experience to sit and be relational in any level with others for some of those, some people anyway. But that once the rewards begin to show, then that must be good.
Well, it is. I mean, certainly in the group that we set up for people who killed somebody they were close to, you can imagine that. I mean, I really take my hat off to the guys who first came, the first 5 guys who came, because, you know, I think we were all we were all a bit scared when we started, the therapist included, but because we weren't quite sure how it was going to go. But we were confident because some other colleagues of ours had done it in the States, so we were confident that it was doable. And we really had a strong belief that actually, given that they were going to have to come up with some kind of narrative about what they'd done to people that they met in the future, that this might be a place where they could practice, and that it would be better to practice it with people who'd done it themselves, and that the only thing they had in common was that they killed somebody that they were close to, and we were quite explicit about that at the beginning. So you just get that out of the way straight off the bat. In fact, we called one of the biggest problems we had was deciding what to call it, and we did call it the homicide group in the end because it's very straightforward. But so that was a sort of, in a way, you didn't have to talk about that anymore because that was done. There's no, well, what did you do? What did you? Nothing of that kind of disclosure. We knew what everybody had done, apart from the therapists. And we used to have a little running joke that there was still time for the therapist to do it. But within that they'd all done the same offence, they were all different and they all had their own story to tell.
Yeah.
And that's
anyway, Ben, thank you so much. That was just really, really interesting to hear.
It has been, absolutely. And we're going to finish at past, so it's not very long. Unless anybody has got any other quick comments or questions. I'll very quickly pitch in just before we finish then. I mean, one is just about the experience of time. Must be very odd.
Yeah.
And therefore what happens to the idea of process? And have we been here before? Yes, we've been here before.
Yes.
Still the same.
For who? For the therapist or the patients?
For the people who can visit, for the people who have to be there. And then the sort of the task of having to bear witness. And I suppose I'm thinking that maybe that's part of the moving thing about hearing you, is just how you equip yourself to bear witness to this, and how much I've sort of noticed in myself that not wanting to actually, particularly, and yet at the same time being deeply intrigued and pulled in. And I think what your talk has touched on in many ways is to make it more feasible, because we can equip ourselves with sensitive description of the territory in theory, but also those factual sides you gave, I thought were very helpful. In just sort of saying, this is the territory. It's not completely shapeless.
And in that sense, this is what doctors do, isn't it? With complicated pathology. Sometimes, surgeons, they have to go to a field of trauma and they have to open it up, and they're not quite sure what they're going to find when they get there. And it could be pretty terrible. And you just don't know, but you have to be prepared to go. But the most important thing, of course, is that you don't go on your own. And this is another reason why group work is so helpful, because you do it with other people. I couldn't have done this work at all without co-therapists, and co-therapy means that you are then there's 2 or 3 minds holding these issues, and that means also that if somebody's got one bit of the elephant, a couple of other people have got other bits of the elephant, and so I think that really means that that helps not to get caught up in traps of either being too lenient or too forgiving or too punitive, or just being overwhelmed by sometimes by the sadness of it, because it is sad. But I guess there's something about being a person who's done something terrible that you can't put right, and yet you have to have a life. You have to have a life afterwards. You kill your dad when you're mentally unwell. What are you going to do with your life afterwards? If you're going to live, what kind of life are you going to live? It's a profoundly existential question. And
yes.
And you know, and it seems to me that, you know, that psychiatrists, psychotherapists have a role, and whatever else we do, keeping people company while they struggle with a question like that is not an unreasonable thing. We don't have to have the answers, of course.
Although I guess we're not neutral either, I suspect. But thank you very, very much, Gwen, for that. It was terrific. And thank you for your generosity, your time, your
thank you for asking
experience,
me.
your thoughts, and actually your hope.